Hello everyone, this is Dr. Khan again. Sorry about the confusion. I'm just trying to get settled, and hopefully this is it, and I'm able to hopefully have the audience join me from my private Facebook support group page. And if you could just please let the other members know from my private Facebook support group page, Breast Implant Illness Support Group page, to come and join me on my public Shaher Khan page. That would be great. So I want to go ahead and welcome everyone, especially to the new members, to any members who want to join. I welcome everyone to my Facebook Live. Essentially anyone who wants to listen, anyone who wants to ask questions. Hopefully I'm able to answer the questions. This is not only for the patients, the ladies who have the implants, who are interested in removing them or learning more about them, but also the significant others who need to understand that this is a serious problem. Not only the significant others, the husbands, but also the many other patients who are potentially interested in getting implants. They need to be aware of as to what they're signing up for. The breast implant illness is a real phenomenon recently, basically getting more and more accepted as disease, as an entity that affects and afflicts the many tens of thousands, hundreds of thousands, and millions. And this is also for the many patients who still have not heard of breast implant illness, so that they are aware that there is this constellation of sign symptoms, whatever they're exhibiting in their young age or their old age, that this is what is breast implant illness. A lot of times I get asked, what is the breast implant illness? Essentially, it is the body's immune response that ends up attacking itself as a result of the implants that cause the toxicity to essentially leak out, and then the body in itself causes a overreactive immunological response that ends up targeting essentially all the cells of the body. And like a very smart patient that said today, and she vocalized this herself, essentially 100% of the patients eventually succumb to breast implant illness, and it's not a fraction of the patients. And this is certainly very true for the fact that number one, the implants are not meant to be there forever, and that the implants ultimately need to be replaced, and they're replete with problems not only from infection, contracture, obscuring a self-monthly breast exam, and also the way they basically attack the body in itself indirectly through the body's own immune response. So I want to go ahead and get started by saying that, I have it, and this is what I was telling my office manager and the rest of my staff, what I would say, what I would call the standard of care. I'm going to go ahead and post a video of one of my patients that I did just recently, where I remove the set of implants, saline, below the muscle, where the implants themselves, saline, were harming the body, and how the shell of this saline implant, which is the silicone, had essentially started to disintegrate, and then the immune response that had occurred as a result of what we know, the giant cell reaction, the multinucleated giant cell reaction that was affecting the body negatively, and which was noted to be chronic inflammation. And it is not only and essentially a removal of the implant plus the capsule as one system, preferably as the end block, or 100% total capsulectomy, plus any inflamed tissue that may be causing the reaction in the vicinity of what would be the implant. So it is integral and vital to remove, and you will see in that video that I'm going to post shortly after this live, where you will see that the entirety of the inflamed tissue needs to be removed in a very meticulous, standardized fashion. I always say I utilize the 100-100-0 rule. I get this question asked a lot: are you able to remove the implant plus the capsule and the entirety of the capsule 100% of the time? And I say absolutely yes. And this is where I say I have it fairly standardized, where 100% of the time I remove 100% of the capsule with 0% of the capsule remaining behind. And this is essentially the gist of this Facebook Live plus any other Facebook Live, and the fact that this is the whole consistency in the operating room, where I know going in my patient's recovery, bounce back health, the good health, the relief from the BII symptoms lies on the fact that the entirety of the capsule must be removed. If any of it is left behind, then you're going to find that the patient's symptoms are not going to be completely eliminated, or the symptoms might be partially eliminated. And so that's why it is integral to removing the entire capsule. As you have seen over and over again, I have posted the many pathology reports that consistently state the giant cell reaction, the foreign body reaction, the reaction to silica, that the body continues to mount, that is seen, visualized in the slides that the pathologists process, which show clearly that the capsule has in it the reactivity, the reactive body's immune response to the silicone. And as my patients know, 100% of the time I send the capsule off to the pathologist once I have removed it from the body, such that the pathologist can weigh in and confirm of what is notable within, and obviously to rule out BIA ALCL, which is the breast implant associated anaplastic large cell lymphoma. There's also been reports of breast cancer amongst the confirmation of what is breast implant illness, known as the chronic inflammation, that is notable. Now, I saw in one of the postings from one of the patients where she had sought consultation with her plastic surgeon, who had said that he would determine in the operating room that what the findings of BII would be, and that he would make a operative decision about what to do and how to interact in the operating room in order to remove the entire implant and maybe the capsule. And I say this is a red flag, and this is precisely my point. There should be a consistent, deliberate, purposeful, very convincing, and 100% motivation with no compromise, the fact that the entire capsule must be removed and there should be 0 capsule remaining behind. No surgeon should say, well, I will decide in the operating room how intense the dissection is going to be, or I will determine if it's going to be safe for me to remove. No, the commitment needs to be made even before, and this commitment needs to be 100% of the time, because we should not, and one cannot decide in the operating room if he's going to go all the way or not. It should be 100% response from the plastic surgeon, and the entirety of the capsule must be removed, for this is where the patient relief lies. Now, having said this, the whole understanding of what is breast implant illness essentially boils down to, again, in summary, the commitment of the surgeon. And what are the ways, and I've mentioned this before, what I call the Khan criteria. Number one, where you can get confirmation that a surgery was done, and in my eyes, from my experience, from my expertise in doing a lot of explants, that the surgery was done right. Because 10 years from now, and this is what I was alluding to earlier, we will still know that this is the standard of care, the surgery that will be offered. Number one, 5 factors that determine that the surgery was done right. Number one, the length of time. It is integral that whatever length of time is needed, that it be taken in order to remove the entire capsule. On average, I've done 4 hours. Yesterday, I did 3 cases. I didn't start my 3rd case till 5:30 p.m. It just pretty much took most of the day for 2 cases alone. And I didn't end up leaving the operating room till approximately 8:45 or so. The point here is that length of time. We cannot rush through the surgery. The smart surgeon is the surgeon who takes his or her time and does a meticulous, tedious dissection, and in a very sophisticated way, such that the entirety of the capsule is removed, literally millimeter by millimeter. This results in a better dissection, less pain, less blood loss, less damage to the muscle or the rib, less chance for complication, and a better post-operative recovery, and ultimately a better cosmetic result. So length of time. Now, in my experience, it's been 4 hours. I cannot imagine this be done any faster in my hands and maybe in someone else's hands as well. You cannot do the surgery in an hour, literally. I have done so many of these, otherwise I would have been proficient enough to doing it. Number 2, the length of the incision needs to be approximately the diameter of the implant. You should not wrestle the implant out. It should essentially crawl itself out by the slow meticulous dissection, such that the entirety of the implant plus capsule is removed without being wrestled out. We don't want to tear the implant. We don't want to tear the capsule. We want to preserve all of the internal contents. Number 3, the pictures of the implant plus the capsule with as one unit, and then afterwards the capsule removed, and then more importantly the picture, the photos of the chest wall showing complete removal of the capsule, because this is the ultimate proof showing that the chest wall, the ribs, the fascia has been removed essentially, and the plastic surgeon cannot just cauterize the capsule on top of the chest wall, because this is where the burden is left behind, and that small amount will continue to haunt and burden and influence the BII. So the entirety of the capsule, 100%, must be removed. And the pictures are the proof that these pictures show clearly that the entirety of the capsule is removed and that there was none remaining behind. Number 4, you always want to get the implants back. This is important and integral to see that the consistency, the implant was not ruptured, there was no damage, and more importantly nowadays, it is very important for the patient to confirm on what they had in their card or what was discussed in pre-op to see that this was not a textured or smooth implant, and to what the location of the implant was, if this was above or below, and all of this is integral. And certainly getting the implants back, it is important. There is no such thing as a committee would not allow for the implants to be given. The implants are not processed, they're not cut, they're essentially passed in a bucket or a biohazard bag and left on the table essentially. The implant should and must be returned to the patient, because this is the proof that the implant was removed and the nature it was removed. Number 5, last but not least, but very importantly, the reputation of the surgeon. I say to every patient, whenever they see me, I make it a point, I tell them, I request them to please write about their experience, to talk about their experience with me, so that I myself have a reputation just like everyone else, and so that the world, the rest of the other patients, get a good sense of comfort, feel, and feedback that how and what their operative experience was, what their anesthesia experience was, what was the standard of care that was provided, and that there is a certain confidence that the patient has in their plastic surgeon. And one must not rush into a surgery. They should feel very confident. They should have a full communication and a dialogue with their surgeon prior to surgery if it's out of state, and also very importantly on the day before the surgery. For example, if you're traveling out of town, and I make it a point, and it's certainly meeting and seeing the surgeon and having the sixth sense that you feel comfortable in making that decision. So I find that is important. Just like anything in life, this is a big decision. The last thing you want is to go back. Today, one of my patients that I saw, who's going to be operated on tomorrow, my 3rd case, she actually has had explantation done in 2018, and unfortunately she suffers from almost all the symptoms of BII except for vertigo, and she has all the constellation and signs and symptoms. And we have seen in the patients that have come forth who have had their explants with the residual capsules, they have to unfortunately undergo a second surgery in order to remove the remaining or the residual capsules, which certainly is another challenge for the patient financially, with the pain and the suffering and also the post-operative recovery. And that surgery is, believe it or not, as challenging, if not more, as the initial surgery where the implant and capsule is removed as one system, as one entity. And you don't want to be that one patient. You want to have that confidence, that commitment from your surgeon that the entirety of the capsule is removed. And the legal bond that you have is that with your plastic surgeon, where the consent must state end block removal of the implant or 100% total capsulectomy, and that 0% of the capsule must remain behind, because that is the agreement you have with your plastic surgeon. There should be no question in your mind that your plastic surgeon is going to make that commitment, because that is entirely the purpose of the surgery. Now, having said this, this is what I would say this is the standard of care. And I was, as I was saying earlier, 10 years from now, 15 years from now, I cannot imagine how, in my mind, eyes, and experience and expertise, how the surgery would be done any differently than what I do now. I always say to all my colleagues, my plastic surgeons, 100% of the time you must send the capsules off so that we know what we're dealing with. What is it that was causing all this inflammation for the patients? Number two, also the microbiology cultures should be done for aerobic, anaerobic, and fungal cultures, which I take 100% of the time on all my patients, because we want to see, sometimes there are biofilms that form, and in it are the bacteria that basically are associated with the implant, sometimes that lead to capsular contracture. Now, I just want to mention a few patients that I've managed and taken care of over the last several weeks. There's a patient that I managed and I saw just a couple days ago. She had history of breast cancer on the right side, and then subsequently she was managed with radiation. Now, she had a partial lumpectomy along with she had a lumpectomy along with radiation, and so she has residual breast tissue, and unfortunately she was managed by what is fat grafting, and then also an insertion on an implant in an already radiated side, and to top it all off, above the muscle. Now, I find three major problems with this case. The first problem here is the implant was placed above the muscle. Number one, the implant should not have been placed because of the radiated tissue. When you have radiation, the entire consistency, the physiology of the tissue changes for the worse. It becomes more leathery, and an implant is not ideal. Number one, they're not safe, but it's not a wise placement above the muscle. And number two, fat grafting. We know on the face where fat grafting is done, in the best of the hands using the Coleman technique, 30%, 40% of the fat dies. And this is where 1, 2, 3, 5 cc's are injected, and this is where you have the best blood supply on the face. Now, if you can imagine, you're going to basically fat graft in the breast tissue or in the periphery of what would be the breast tissue. You're going to have fat necrosis that is going to inevitably occur in almost 40, 50, 60% of the time. 40, 50, 60% of the fat that is going to be fat grafted is going to necrose. And this is going to happen 100% of the time, that a good half, if not more, of the fat is going to die. And then all of a sudden, this patient who I saw, she has irregularities, inconsistencies consistent with what is fat necrosis on an already radiated field, and in a patient who has history of breast cancer, and now subsequent mammograms that are done only complicate and basically confuse and cause anxiety in the patient, and basically provoking unnecessary biopsies, which I would say, in my eyes, is what I would consider malpractice, and unfortunately happens. So this is something that I wanted to bring up and mention. Fat grafting is not a smart and wise idea. Especially in such or any case, if you ask me for fat grafting to the breast tissue, where 1 out of 8 or 9 women are going to get breast cancer, and I would not recommend this at all, and it does not sound logical, and it is absolutely what I would say very unreasonable and consistent with what would be malpractice. I'm a big fan of DNT, do not touch, no unnecessary surgeries. We have one goal of life, essentially, which is to all live healthy, no visits to the doctor unless required or for screening purposes, and to live a long life without any scarring or any problems. Breast implants, as we all know, just given the recent FDA warning that now is required and mandatory for the plastic surgeons to discuss with all their patients, and hopefully it gets translated to the patient and there is part of informed consent. The augmentation, be it with saline or silicone, is replete full of problems. As I mentioned earlier, you have infection rate, contracture, you have basically association with what are textured implants and the BIALCL, not only in textured patients, but believe it or not, the smooth implants have also been noted to be associated with BIALCL. You have the physical exam that will certainly be obscured by what would be the implant, and you have the foreign body reaction that will compound the picture, plus compromise of the upper extremity function, amongst the many other reasons, including not being able to get an optimal mammogram just because the implant would be getting in the way, and certainly hurts the body. And the augmentation certainly, hopefully, should not be done, according to my expert opinion, according to my medical knowledge. And this is something, the augmentation is replete and full of problems. The implants are not meant to be there forever. We all know this. This is established. Implants have been banned before. They have been taken off the market from 1992 to 2007, where the silicone implants were essentially taken off the market. And we know from the many studies, the many associated connective tissue disorders, along with problems such as Sjogren's, especially the big study, the study of studies out of MD Anderson Cancer Center in Houston, which has looked at 100,000 patients, 80,000 with silicone implants and 20,000 with saline implants, where you had high association with stillbirths, Sjogren's syndromes, joint connective tissues. And we also know this exists from the studies that the manufacturers have put forth in the recent past. And last but not least, look at now the mountain of evidence that has come forth from the many hundreds and thousands of patients who now have joined together on social media and now are very openly and very bravely sharing their experiences of what is breast implant illness, and confirming that we have known all along what is the suffering and the misery that the implants cause, not only to the patients, but everyone and whoever is around them. I want to go ahead and mention, there was another patient that came to me, I just talked to, from Washington State, that I operated on. She had a latissimus flap. And so another patient that I talked to from Tennessee, and she basically had mentioned that she had a latissimus flap. The latissimus muscle is the one that's on the back, and that's usually rotated in, especially in a radiated field, that basically brings in the muscle, the blood supply, and essentially is used to reconstruct the chest, and usually with an implant in order to basically add volume to the chest. Now, this one patient said that she had sought consultation with two other plastic surgeons in Tennessee, and the same patient that I talked and mentioned earlier, one must and cannot get a compromised care by saying, oh, you have a latissimus flap, that muscle flap might die if the surgery is done inaccurately or not carefully, and because of the old scarring, and any kinking of the blood supply may compromise. I must say with confidence, with 100% certainty, that patient must get the same surgery that the 26-year-old gets, that the 72-year-old gets, the one that I operated on. And again, it's the same consistency in everyone, regardless of what their ejection fraction is. A patient who I talked to recently who had an ejection fraction of 45%, or another lady who had severe pulmonary hypertension, or another patient who's on a blood thinner, or another patient who's 81 versus someone who's young and 22. They all should get the same surgery. There should not be variations in the surgery. And again, the whole goal and gist of this Facebook Live and the whole gist of the whole operative experience is to get the entirety of the implant, 100% of the implant and capsule removed as one system, and to leave no burden behind. And one must always, as a plastic surgeon, assume that the implant is ruptured till proven otherwise. You may have the MRI without contrast, which is the best of all the studies that exist in 2020. There have been many cases where I've operated on what was a normal MRI of the right chest, and it turned out in the operating room that it was indeed a ruptured implant, and that was all contained in the en bloc fashion without the need for drains. Now, I have a lot of friends, plastic surgeons. One of my plastic surgeons who I talked to last week, who is actually a fan but also a critic of mine, and again, as we know, many of the plastic surgeons don't accept what is breast implant illness. Many of the doctors, rheumatologists, endocrinologists, primary care physician, family medicine doctors, none of them accept breast implant illness to be an entity. It's not given any weight, it's not given any recognition, and essentially all the patients who have gone through this several tens of thousands of dollars of workup, they're essentially told you have psych issues, depression, anxiety. Number 2, fibromyalgia. We need to get a urine tox screen. You might be on drugs. Number 4, you're getting old. Number 5, you might be told that you have what is a variant of Lyme disease, lupus, variants of some other psychosocial stressors, maybe COVID, amongst many other things. But the last thing that's even factored into the equation is the breast implants. And certainly this needs to be recognized more and more. And now, as you will see, many of the patients who are now bringing forth to their doctors, it's the implants. And we're starting to see this more and more in the Cosmopolitan magazine, for example, or the Fortune magazine. And there is a recognition on social media amongst the many other modalities. I say this to everyone. Today I talked to one of the the TV reporters from Grand Rapids, and I'm going to get interviewed in regards to what I think is breast implant illness. And I said, certainly listen to me. I'm going to interview with the TV next week. And I said, just go to my Facebook and just listen to the patients. You will see the patients in their masses, their significant others. Everyone attests to the fact that, and what is breast implant illness. I say, one of my patients who actually explanted in 1989, and she initially had set of implants, if I do remember correctly, in 1981. And then she suffered through what was breast implant illness, and she intuitively and through her judgment and given her contracture that had occurred repeatedly, ended up getting explanted in 1989 minus the capsules. She is writing a memoir. She basically has had a request on my Facebook page. Sydney is her first name. I say to everyone, write about your experience. If we write about it, we talk about it, it will get passed on. The same patient that I just talked about with the latissimus flap from Washington, she said she ran into my webpage and my Facebook by accident through someone else who had forwarded a message. And that was that one instance that basically led her to my Facebook. And the next thing you know, she made a trip all the way from Washington State all the way to Michigan. There are patients that have come my way after having gone to the Cleveland Clinic, even from the Mayo Clinic. They have been worked up and they've been told by the neurologist, by the rheumatologist, that they basically have a clean bill of health and that essentially it's their psych. And this is where their family members question the fact that where and why would you go to someone? And now you hear the patients directly state that they have had this bounce back. There is no placebo effect, and you will see the patients in the masses who talk about why this surgery is curative, essentially in 80, 85, 90% of the cases, and that there's an overwhelming response, positive response when the surgery is done right. And you're going to see usually within hours of the surgery itself. So I say this to you, that this is something that is very much real, and that this is something hopefully will become the accepted norm. And hopefully, ultimately, I am optimistic, and I can see that just within the last year or two, there have been major steps that have been undertaken that are basically slowly but surely indicating to what would ultimately lead to a ban of the implants, and that will be the best thing for the patients, putting a halt to the augmentation till we figure out what is this insanity, what is this unfairness that the patients are experiencing, and that we should stop hurting, and that we should help the many thousands who are hurting in the fashion that they are. Now, having said this, I also want to go ahead and mention and extend on the fact in regards to what is a lift. Many patients ask, I've had many patients just this week between Monday and Wednesday when I had clinic, ladies in their 50s who came to me, and even the same patient from Washington State that I just talked to, where they stated that they absolutely did not need a lift. And in my expertise, I will say with confidence, and certainly there are so many factors that determine the recoil nature of the skin. You have the genetic factors, you have sun exposure, alcohol intake, smoking, medications such as prednisone, the nature of the implant, the placement of the implant above or below the muscle, the overall inflammation that might be present. Sometimes there is less inflammation, sometimes there is more, sometimes there is a rupture. So all of these factors ultimately determine what the recoil nature, and in my experience, almost a good 70 to 80% of the patients do not need a lift, period. And I say this, certainly the one person who has an 800cc implant is very different compared to the one who has a 175cc implant that I removed. But I will tell you, just overall from my experience, 70 to 80% of the patients do not need a lift. And I make this bold statement from my experience of having done so many. And the patients themselves will attest to the fact you do not have to get a lift. And, this is again one of my friends who basically is a big, what I would say, and this is a friend that I've known for over 20 years. He basically summed it up very well. I'm essentially the only plastic surgeon that he knows of in the world who does not place drains. And I can say this with confidence, and I've placed drains in less than 5 patients this whole year, maybe the last year and a half. And only in those patients where the implant had ruptured and there was essentially free-floating silicone, and that determination was already made. And I've been able to rescue and essentially do an end block, and I've been able to contain all the badness where the need for the drain is not required. And I'm the only plastic surgeon who does not do a lift. And I will tell you, I'm happy to state I don't do a lift, not because I do not know how to do one. Absolutely, I know how to do one. You can, doing a lift is a very simple process. You essentially dissect around the nipple areola. You find the sternal notch to the nipple areola position, usually at the 21-22, and you essentially have the highlights of what would be a mastopexy, essentially, and that's the term. But majority of the cases, when you remove the inflamed tissue, the tissue recoils back 40%, 30%, maybe up to 50%, depending on the age, depending on the placement, if it was technically and very proficiently placed. And this does not require the need for a lift. And on a day when the commitment by the surgeon must and should be to removing the entire implant and capsule, and the fixation should not be on the lift. And so this is absolute. And I tell the patients jokingly, I love to operate. I would, on a given day, if I had time off, I would probably be operating. After the Thanksgiving break, I was actually very happy. I was heading back to the operating room, and I would love to do more surgery, but I hate to, and it is not required to do any unnecessary surgery. It is going to be essentially unacceptable to do surgery where the tissue and the body in itself, when done right, as you will see, the many ladies who are now the proof where you can get away from doing a lift in good 70 to 80% of the patients. And I again say this with confidence, for the betterment of the patients, for the good of the patients, and simply, do no harm, going back to the basics. The other thing I want to mention is, there are some surgeons that I've seen actually go make a up and down incision. Essentially, they're committing the patient to a lift. That's why they do that. Or they go in and around the nipple areola. And I say that's not a smart or a wise move, especially when the implant is placed below the muscle for many reasons. Number one, accessing the implant through the nipple areola or inferior areola or the up and down, what it will do is, number one, cut the ducts and also the nerve endings that supply the nipple areola, at least on the lower half. Number two, one has to commit to the length of the incision. We don't want an incision in the center part of the chest. A scar that's going to be unsightly might lead to hypertrophic scar. As you will see, sometimes it widens. So the ducts, number two, the nerves. Number three, you're going to be dissecting through the skin and putting a scar in the center part of the chest. Number four, you're going to be dissecting through the breast parenchyma, the breast tissue itself. And that in itself will lead to scarring of the breast tissue and distortion of what would be the natural anatomy of the breast tissue, especially in someone who's young in her 20s, 30s, and 40s. And that may get picked up with a questionable mammogram, maybe a necrosis or a scar tissue or a palpation of what might be an internal stitch that might lead to fat necrosis. And number four, you have to cut through the muscle, and you don't want to be cutting through. If you type in on Google pectoralis muscle, you'll see the pec muscle essentially originates onto the sternum and the entire chest area and then inserts into the humerus. We don't want to be cutting through the muscle in order to get to the implant. The smarter, the ideal way, what I will say from my experience, is to do the inframammary or below, such that the inframammary ligament is not violated, and this is a scar no one is going to see unless you're in the mirror, and it allows for a nice generous incision that certainly will allow for delivery of the implant and capsule and optimal visualization, and to allow for dissection directly above the ribs, which is where majority of the implants sit when done by a board-certified plastic surgeon. So I just wanted to go ahead and bring that up. This was a discussion I had with one of my patients just today. So now, having said this, what I'm going to do is, I'm not computer savvy. What I'm going to do is I'm going to see if I can find out some of the questions. So I am starting to see the questions. So I my friend from Washington State, who I just talked to, she's watching. I talked about you since you were fresh on my mind. I'm going to go ahead and request any questions that anyone may have. So this is a good question. At what point do capsules form completely? Can they be removed early within several months of the implant? So from my experience, usually, last winter break, a lady had implants inserted, and she was from New York. She called me and she said she just had them done 2 weeks ago. First set of implants that she ever had, and she knew the moment she got out of the recovery and later on that night when she got up the next day that she wanted them out and they were not for her, and she made a bad decision. So she called me and asked me the same question, and I say this to you: it takes approximately 6 to 8 weeks for the capsules to start forming. Now, this has been reported by the many surgeons anecdotally and also in the textbooks. If an implant is basically inserted, it takes approximately 6 to 8 weeks for the capsules to form. And then the capsule removal becomes essentially important. So in this patient who had implants just 2 weeks, very unlikely that the capsule would have formed. And I told her, get on the plane, I would add her on as a fourth case. And very likely, if I were to visualize through my special loops, my magnified loops, that there is a capsule, I would certainly remove it. But in 2 weeks, it would not have formed, because there are many instances where I myself have gone, especially when I was in training, where the capsules had not formed, especially in cases where we had to go back. Say, for example, someone had gotten an infection, in my training, then in 2 weeks we saw clearly that the capsule had not formed, and it is being shown that roughly it takes 6 to 8 weeks for the capsules to form. Can they be removed early within several months? So I have to say after 2 months very likely they would be formed. Is an end block necessary if there are no signs of BII? Now I want you to understand, there is a patient that came and said, I want the implants out and I'm not having any signs symptoms of BII. And as you will see, many of my patients themselves, and I want them to come forth and state, they thought that they did not have signs of BII. They thought this was them aging. And once the implants were removed, they were like, wow, that symptom was also like a BII symptoms. The GI issue was a BII, like a symptom of BII. The vision problem that they were having, they thought they were basically just needed some new pair of glasses, or memory issue. They thought they were in their 50s. This was the old age and the dementia hitting them. This was indeed what was BII. So end block is necessary because you never know. Sometimes patients come and they have a ruptured implant, and believe it or not, they did not even know it, even when they had an MRI that showed that it was intact. So always approach. Now, this one patient that I mentioned, she had the capsules residual. She thought that she was just afraid that she had another patient of mine, for example, and again, I want the patients to kind of comment and share with us their experience. Their patient came and she said that she had textured implants. She was afraid that the capsules that were left behind would eventually trigger and potentially get cancerous, and hence her concern was she wanted to go ahead and remove, and she's a patient on my private breast implant illness support group page. So she came and she got the capsules removed, and lo and behold, post-operatively she comes back 6-8 weeks later and she says, nice young police officer, and she says, wow, my symptoms, that's gone, and she literally checked, and you will see her feedback on my private breast implant illness Facebook support group page, that indeed she had those symptoms. The point I'm trying to make here is every time an implant is there, the approach must and should be end block, because you never know what you're going to encounter. So going back to what I had mentioned earlier, the next video that I'm going to post of my patient where it was saline implants, we know it was not ruptured. The patient overall was doing well, and lo and behold, when I cut open the capsule, as you will see, the saline implant looked very creepy / calcified, irregular, with what appeared to be silica within. There are patients where I've removed implants. The patient is essentially asymptomatic, and lo and behold, there was, through an aspirate, an infection of within the implant, but nothing around. I just want to clarify, and again, I get this asked a lot. Thank God to date, as everyone on my Facebook page will support, and as I say this publicly, not a single patient of mine, an explant patient, has had an infection. And thank God, the sterile technique, the certified surgical center that I operate out of, the board certified staff that I have, the center of excellence / the care we take, everything is done, and I use the word to the best of our ability perfectly, such that there's no surprises, and we're continuing to offer the same to our patients. Next question. I'm scrolling down to see. I just asked my office manager today, how can I see the questions? Because lately, as you will see on the many Facebook posts, the Facebook lives, I've not been able to see these questions. So do you require an MRI before an explant? Now, I say this to you. Just on Monday, 48 hours ago, 55 hours approximately ago, I saw a patient, nice lady, a nurse, very well informed. She had implants from 1980. I can tell from my experience, these are 40-year-old implants, and 99% chance they're ruptured till proven otherwise. My first question to her were, hi, how are you? Did you get an MRI? I want an MRI. And she was a nurse. She was on top of her game. She said, I got the MRI already. I know in this case, I want an MRI because it's very likely ruptured. Now, she said that the implant, the MRI shows the left is free floating silicone and on the right, it's contained. Now, I'm going to start off on the right. Had it been vice versa, I want to do the easier side first, the more complicated side second, because I don't want any potential cross-contamination, number one. Number two, in patients who have had old set of implants, very likely, or the first, second, third generation implants, very likely they're ruptured. I want to do a nice game plan. I always tell my patients, we're preparing for the big day. What's the worst thing that's going to happen with the MRI? The MRI is a magnetic resonance imaging. It is not radiation. It's safe. It's without a contrast. The two downsides of getting an MRI are $350 nowadays if you have to pay out of pocket. And number two, 1.5 hours, 2 hours you're going to waste. But guess what? We have a whole set of information that we can get to plan our surgery. And I say, preparing for surgery is like a Navy SEAL mission, if you will. The goal is come down from the helicopter, and I say this jokingly, come down, run into that room, you have done the planning, get the bag, and run out. You don't want to get shot. You don't want to get into trouble. Same thing on the operative day. The goal here is to go into surgery knowing what's going on, to go into surgery with the old set of implants. What is the lymph node status? So a case that I'm doing tomorrow, we know that this is a rupture. Lymph node status, I want to know, just so that if there is any spillage, what is the extent, where is the way I can dissect, what is the best way of approach. It guides me. There is no harm in getting the MRI. It's not overkill. And remember, the FDA, when it first came out, the set of silicone implants, they recommended getting the first set of MRI at 3 years after the augmentation, and then 2 years there onward, every 2 years, believe it or not. And you can look it up and confirm. What I want to do is on the day of the surgery, I want to know, I want to plan it, I want to know what we're dealing with. I want to know, it makes my roadmap better, just like that Navy SEAL mission, if you will. It gives me comfort, it gives me more of a security that I've planned the surgery better. Now, having said this, we know on one Thursday, for example, I had I do 3 cases usually on a day. The first patient had an MRI that showed that the right implant was ruptured. And lo and behold, when I cut open the capsule, the right was intact, the left was ruptured, and it was the other way around. The third case that I had done that same day, MRI showed both the implants were ruptured, and there was essentially extra capsular presentation of the silicone. And believe it or not, in her, both of the implants were intact. So the MRI was wrong, despite what the MRI was supposed to be the best standard. So to answer your question, the MRI helps guide. Now, I don't want an MRI in everyone because it's not going to change my management. I always approach every single case that is going to be an end block because I don't want any spillage. I don't want to be having to put drains in. That's why I go slow. And I always commit to an end block because I know going in, this is what the patient needs. I don't want to be, because I do not know what's inside or underneath the capsule. Sometimes you can tell by touching, but the only time you find out when it's truly ruptured or not, even if it may be a gummy bear implant. From 3 years ago, a young lady in her 20s, gummy bear ruptured implant, believe it or not, and this is part of my private breast implant illness support group. So the point here is the MRI guides and helps and assists me for the surgery, and it helps plan it for what would be minimal to no risk. And so I find that the MRI is key in patients with old set of implants, not the one from 2016 or 2012. And I always approach it in the end block because I never know what I'm going to find when I open the capsule up to reveal what is the consistency and what is the nature of that implant. I had my implant for 19 days. Do you think I need an exploratory surgery, especially though I had textured implants? Now, I'm going to say 19 days is not much. So I know going in from my experience to having answered this question again, very unlikely you have formed a capsule. Now, I go in, and if I find any abnormal inflamed tissue or reactive tissue, I'll remove it. But very unlikely in just under 3 weeks that you would have a formed capsule that would be removed. Does the MRI detect a rupture? So no, MRI contrast is toxic. There is no reason to get an MRI with contrast. The MRI is done without contrast. In order to do an MRI with contrast, that imaging study is done for patients who have a mass in order to rule out breast cancer. And remember, the purpose of my operation, the purpose of my consultation is to make sure that the implant is not ruptured, and hence the MRI without contrast. Ultrasound is technician dependent. Sometimes if you have a thick capsule, the waves will not penetrate the thick capsule, and it may not be an ideal test. And it's not the gold or the standard of choice, standard test that's done. The MRI without contrast is the best test. I have saline implants. I forgot to mention in my MRI. So saline implants, the best patient I have is the patient who has saline implants above the muscle. We know saline implants, once they rupture, they're like a water balloon. They're essentially going to deflate, and you're going to be flat chested on one side relative to the other. Above the muscle is easier dissection, better dissection, and the patient bounces back relatively nicer because the dissection below the muscle is not done or above the ribs, and essentially it's underneath the breast tissue. The hardest one is the set of implants below the muscle, old generation, the Dow Corning, the ones that were recalled, or even the ones that were from 10, 15 years old, or even 1 year old. And it is involved, and it is a very meticulous surgery. So just to let you know, another patient that I saw just today, she had a set of implants placed in the early 2000s, and in 2019 she decides that she wants to go ahead and get the gummy bear, the newer generation silicone implants, and supposed to be the newer model, the safer model. In 2019, and she was overall doing well, fine. And as you will see, this is anecdotally, a lot of patients will present and come forth and mention this. So she, in 2019, just 1 year ago, a year ago, goes in and has the initial set of implants removed and gets them exchanged with the newer generation 2019 implants. And lo and behold, once she gets the surgery, she has all those symptoms of BII, full-blown symptoms, and she looks sick, she's fatigued, brain fog, and everything that you can imagine. I saw her today. The tingling numbness in her arms had come down, her face was glowing, and all the symptoms, and it was that stirring up phenomenon that had essentially caused her to succumb to the BII all of a sudden, essentially just 1 year out. And so this is the quote, the toxins that were essentially stirred up that caused her to have this reaction. So the point here is that even if it's a newer set of implants or old, the body in itself will react. Sometimes patients have had it for 20 years and no problem. And I say good for those patients, but ultimately the implants are not meant to be there forever. Why do most of the other surgeons use chest drains? How do you get around requiring them? So that's a very good question. I get this asked a lot, not only by the patients, but by, believe it or not, other plastic surgeons. Now, number one, I take my time. I dissect. And I say this to you in the manner that I know you will be able to comprehend even if you are not surgeons. If I give you a piece of paper, right, for example, I have this piece of paper here, and I give you a pen and I say start coloring and fill in the void. You will notice, let's say if I were to go to a class of 30 kids and I were to say here's a blank piece of paper and here's a pen, I want you to color. The Boy in the back literally will take the pen and color the whole thing, and probably in 2 minutes, and say, I'm done, next. Likely the girl in the front, who 2 minutes into it will say, what are you talking about? I'm just getting done with maybe 3% or 5% of my project. I thought I had another 3 hours. The very meticulous, tedious, sophisticated dissection, as you will see in my many videos. I want you to please go to my YouTube page, Khanplasticsurgery Academy, and where I do the dissection live, i.e. you can see me dissect. It's a bloodless field. The dissection is done with precision. I'm not cutting into the muscle. I am removing the entire capsule. I'm not leaving any inflamed tissue. I'm not breaking into the implant capsule. I'm not doing anything exaggerated. I'm not rushing through the surgery because I have the next patient waiting. I tell this next patient, I'm sorry to be blunt, they knock on the door at the hospital and say, Dr. Khan, when are you going to get done? I say, by midnight. Jokingly, I said, don't bother me. I'm going to take whatever time I need. Yesterday, for example, I did the case, and this third patient, literally, she had a young mom, God bless her soul, very understanding, super nice. Her husband, when I walked in the door at 5:30, another time it happened a month ago or so, like 4 or 6 weeks ago. 6:30, I started my third case, and I look at him, and they are like, we're hungry and tired. And I said, I'm so sorry. I didn't know it was going to take this long. And this is where the careful, delicate dissection leads to better results, less trauma, less pain, no need for drains, and it is literally done millimeter by millimeter. And believe it or not, sometimes I hold my breath and I dissect, and this is while the patient is breathing, because I'm dissecting right off of the ribs and I'm removing everything. And this is where, when I get done, I feel like I've been exhausted, like I ran a marathon, especially on a day like yesterday when I didn't leave till 9, approximately 8:45, 9 is when I got done. I did not leave the clinic till 9:30 or so. So basically that's the answer. And the proof is, look at all my patients. Look at my hundreds and literally all the patients. One of my patients came to me in pre-op, very nice lady, I'll never forget. She had a nice smile on her face, and she said, all the doctors are putting in drains. I want you to please put a drain in. And I said jokingly to her, I'm not going to put in because you're too nice to me. I'm going to put one in because you need one. If the thought crosses my mind, I have to put a drain in, I'll put one in because I can always remove it. But in my mind, when I did the dissection on a lady that had 800cc implants on prednisone, and I used my sixth sense and I said, I can do without a drain, or the patient with the ruptured implant that I saw today, young lady in her 20s, and I was able to contain it and unblock in a very sophisticated, very tactful way. There is no requirement for a drain. Look at those videos. I've had SICU and ICU nurses and operating room surgical techs that have come my way, and they came just because they saw how I had done my dissection. And I'll tell you, there is no requirement for a drain. Now, I do tummy tucks, I do abdominoplasties. I put not only one drain, I put 2 drains in. Because the drains are required, that's an extensive area given the nature of the dissection. And even then, I'm able to, in the last tummy tuck I did, believe it or not, I put 1 drain. I felt that I did not need to put 2 drains in because I knew my dissection was pristine and in the right, what they call the avascular plane, where the blood amount of blood discharge is usually 5 cc's each side. And I'm able to do it super tactfully. And I can say I have probably in my entire life put in less than 15 drains. And I say this to you with confidence, with a whole series of patients that have come from far away, where I can say with confidence. One of my other patients, she critiqued me, and the other plastic surgeon, he critiqued me. And he said, I have 3 things that no plastic surgeon on earth has. And unfortunately, or fortunately, and I say this is my training, this is what I have to offer. And in some sense, you can say this is what one of my patients said, this is how I draw my art, if you will. Number 1, I'm the only plastic surgeon on earth, according to the one patient from Corpus Christi who came in, very smart lady. She had done like what I would say a PhD in BII. She said, "You're the only board certified plastic surgeon who is not augmented." And I said, yes, except for that one case in order to get board certified. She and the plastic surgeon colleague of mine said, "You're the only plastic surgeon who consistently does not put in drains. 99% chance or higher you're not going to get a drain if you have saline implants. 99% chance or even higher you're not going to get drains with silicone implants. Even when they're ruptured, I'm able to contain it in the way because of that slow, tedious dissection. That girl, i.e., or the boy that's sitting in the corner, just taking their time, drawing in very nicely so it's done perfectly right." And then the third thing, I'm the only plastic surgeon, and literally this is what she said and the plastic surgeon said on earth, who's deliberately not done a lift because the patients did not need one. As simple as that. And trust me, I would love to operate, and I would love to, like one of the other plastic surgeons said, you would make more money. And I said, it's not about the money. It's about doing the right thing for the patient. And just imagine if I did a lift on every patient. And it's all about what I have to offer from my experience, what I feel is the best for the patient. I've had patients that came and said, "I'm not going to choose you because you're not going to do a lift." And I said, please, by all means, I'm not going to do something where you're telling me to do something that I don't feel comfortable. For your own good, from the bottom of my heart, as a board certified plastic surgeon, I wish you the well and I want the best out of you, and that's why I'm not going to do a lift for you. So hopefully that answers the question. I have saline below the muscle. I have saline below the muscle. What would you recommend? I had the saline below the muscle out in. Now you likely have residual capsules. Now depending on your checklist of symptoms of BII, if you have had implants removed, minus the capsules which were left behind because the other plastic surgeon did not remove them, and you are happy, you're sleeping well, no GI issues, no mentation, no brain fog, no fatigue, no signs, symptoms of any breast implant illness, then if it ain't broke, don't fix it. Be happy, enjoy. And there are some patients that I've taken care of where I sent the capsule off, and believe it or not, the pathologist said no inflammation. I said, good for you. There was nothing, and this is what the pathologist read, and they didn't see any signs, symptoms of reactivity, and I said, good for the patient. So if you have no symptoms, if it ain't broke, don't fix it. Leave it alone. I have the silicone cohesive gel allergen implant. Now, I will tell you, it's not required, it's not mandatory, but it certainly helps plan my surgery. Nowadays, if you call an MRI place, in every major city of the US, even small cities, there are imaging centers that have popped up where if you pay cash, they'll literally, without any exaggeration, I've seen and heard $275 to $350 cash. This is what I would say would be a reasonable amount, just so that it will help. Now, I'm not absolutely fixated on getting an MRI. Sometimes it helps me plan the surgery better in cases where, if I know the right side is ruptured and why is the patient having pain all of a sudden 27 years into her. So I know what we're dealing with. Sometimes it helps with some patients where the insurance company says, oh, you have a rupture, an MRI proven, we understand what you had. Now, this is, again, getting more data, planning the surgery for the big day. We want all the information. I don't want any surprises. The two other things that I require and mandate, I do not mandate MRIs. There have been many cases where the patient said my insurance is not covering, or they're not approving the MRI, or they want to pay a deductible that's $1,600, because this is essentially a total ripoff by the insurance companies, especially when you can pay out of pocket and pay a fraction. And that's a topic in itself. The insurance companies are only out there to make money for themselves. We know this. Any insurance expert, and I've met so many that have come my way into my clinic, the insurance companies could care less about the patient, could care less about the doctor, could care less about the hospital. Their goal and motivation is only fixation off how they can save money and how can they save the millions, and essentially burden the patient without any thought, without any heart, and this is unfortunately was not even well recognized. The reimbursement rates are just too shabby. Believe it or not, just today my office manager told me one of the reimbursements from the insurance was $425 or $475, one of the two, and then the $700 was passed on onto the patient, and that was the only extent that they were covering for this surgery. Now, where am I located? Please, I want every single patient. You know, I had 2 patients on Monday that I saw. Nice ladies, like me, old-fashioned. They were not into Facebook. I told them, you have a lot of homework. You have to go home, log into the Facebook, and go into my private breast implant illness support group by Shaher Khan. And I want you to see how I do, what I do, why I do the way I do it. And most importantly, I want you to go and see all my patients, what they have had to say about their pre-op, post-op experiences and what is expected, because this is truly part of the informed consent. I have had patients just today that came, I examined them, and I asked them, do you have any questions on a topic that's so controversial, that's all the doctors, if I grew up 100 subspecialists in family medicine, internal medicine, GI, nephrologist, endocrinologist, rheumatologist, cardiologist, anesthesiologist, dermatologist, any subset of doctors, allergy, immunologist, and I were to tell them BII, breast implant illness, they all negate it. And these ladies, they come in, they have done their homework, they feel comfortable, they feel confident about what they're doing. And you know, I asked them, what % chance do you think? I'm going to take 100 steps back. I have nothing to do with the conversation. And I tell them, what % chance do you think you yourself have BII? And I say, this is you and your research, and you up at 2 in the morning kind of relating to another patient who had an explant. And they say, well, I have the same symptoms that she had. She's 33, I'm 37. I have the brain fog, the joint pain, the difficulty getting out of bed. Look at my face, look at the lower shadows of the eyes, and look at how my whole GI system is affected, my aversion to food and everything. And she's like, wow, she's improved. All the workup is negative, the imaging is negative, the lab workup is negative, and lo and behold, she's like 100%, I have BII, because what else could it be? And so this is that movement, this is that force that's coming forth and essentially empowering the women and saying, we're not crazy. And I say this to you, absolutely, you're not crazy. And you have every right, because you're hurting, and you should not accept anything else. And I will say this, I'm only enabling and facilitating what I'm hearing from the ladies. Look at all the plastic surgeons who are doing the surgery right, and where the patients are bouncing back and how they're bouncing back. This is not a placebo effect. These are young ladies and ladies in their 40s, 50s, 60s, 70s, and 80s who have been hurting and who've been hurting for such a while. And now all of a sudden they have good resolution of their symptoms 85-90% of the time. So, you know, for me, I'm a one-person group. Now, I say this to you, I wish that I was at a university setting or a company setting where, you know, just to run a good research, you know, you cannot just start compiling data here and there. It has to be as a biochemist, as someone who's involved in research heavily in the past. You know, in order to produce something of substance, of volume, it has to be done right. Otherwise, don't do it. So it needs IRB approval. It needs 2 people just to process data. It needs questionnaires that need to be very objective and standardized. It needs to be done as a cohort, basically a prospective randomized study where the patients come in before surgery, they answer questions. Then 1 month later, 3 months later, 1 year later, long-term studies. And then we need to go back and look at a subset of patients who had capsules that were left behind and just the capsules were removed. That's my 3rd patient tomorrow. We need to do this in a very systematic, very smart way, such that when we produce the data, no one's going to challenge, no one's going to question. And we have concrete evidence that basically points to a large subset of volumes. And this is hopefully where the FDA or big university settings, and hopefully I will not be surprised if they do over the next for several months or years, come forth and say, you know what, we need to start studying. Look, Dr. Feng out of Cleveland published her largest series and data. Good for her. I salute her for being the big leader, the force that is basically going to spearhead this, and the many other surgeons, you know, who basically starting to compile data, but it needs to be done in a very sophisticated, very scientific way that has validity to it, and that the critics cannot question. Nowadays, we have all these patients that are coming forth, patient after patient who is getting the explant, and that's the volume that's speaking. As you have heard me say, the patients, there's 4 groups of people in all of this. The plastic surgeons, no one's talking about BII. The vast majority of say this is a myth. Number 2, the manufacturers, they're laughing themselves to the bank. They're basically very happy. They're like, implants are safe and effective. That's the 2 terms they use when they have data themselves in their brochures speaking for the safety and slash the 1.8 or 2.4% who have these symptoms, and a small subset which is inaccurate. Number 3, you have the FDA that's essentially, unfortunately, I use the word sleeping or too involved in the bureaucracy. All what I say to the FDA is just, you're more than welcome to come and shadow me anytime, hopefully given the patient's permission, and listen to the patients themselves just in my clinic. Had you just spent the Monday with me or just today, you would have heard it from the patients themselves, and you know, there's ample evidence. Now 4 is the patients. The patients are not talking in the masses, and that's reacting to the FDA, and the FDA is basically putting out these warnings to the other 2 groups, and that is basically what's bringing forth the change. And this is why I say this Facebook Live hopefully is going to convince one patient to not get an implant, to convince another patient to get the explant and the end block done in the right way. We have achieved the purpose today then. And this is where educating, and again, I mean no ill will. I don't want to be condescending. I don't want to be rude. I'm just trying to, as a physician, as an MD, as a board certified general surgeon, as a board certified plastic surgeon, from what I have seen with my own eyes, from what I've heard from the patients directly, what I have put the 2 and 2 together, all what you need to do is just look at my Facebook or my YouTube page, and you will be convinced that the implants are horribly bad. And there needs to be a halt to this so that the patients basically regain their health and their basically their lives. So now I'd like to be, I speak my mind. I don't want to use the word, you know, this is me. If you come to my clinic, this is how I am, and I am free from my expertise. All what I'm doing, you know, is helping and trying to help the many patients. I have not in my mind hurt anyone, and I have done the surgery, what I would say, relatively safely, and again, for the betterment, for the better health of my patients. Okay, I'm going to go ahead and scroll all the way up. I missed part of this. Do you recommend an end block only? No, so the word end block, I want you to go please to my Facebook, to my YouTube page, and I want you to see this quote, this short video where I highlight what is end block, total capsulectomy, partial capsulectomy, and a capsulotomy. So 4 different terms. End block basically means, now there was an article in the White Journal, which is our journal, what is an end block? Normally it's referred to a cancer. Essentially, this is a term where the entire implant and capsule was removed as one system, as one entity, where there was no breaks into the capsule, such that if God forbid there was a rupture or a problem inside, mold, bacteria, whatever it may be, a leaky implant, everything was contained and there was no spillage. And the proof you have is the patient didn't need drains. That is the best and the gold standard. And one may not and will not know, even with a negative MRI that shows everything is good, you could still have a ruptured implant. That is the gold standard. That's the best, the most sophisticated, the right way of doing it, such that the entirety of the implant and capsule plus inflamed tissue is removed. This now, during the dissection, because the implant was tightly adherent to the rib, or for whatever technical reason there was a small break into the capsule such that the surgeon visualized the implant, that all of a sudden does not become an en bloc. It becomes a total capsulectomy where the entire capsule was removed, total meaning 100%. And maybe the capsule was paper saran wrap thin, which we have seen on the videos. But the entirety of the capsule was removed. That is a total capsulectomy. Now that is the next best thing. That is true for a saline implant or any implant that was not ruptured. But again, there was no spillage. There was no leakage, or there was no falling out, or there was no extravasation or removal or leakage of the badness of the implant. And one may not know till someone opens. So that's why you want to preserve everything. And it can certainly be done in a total capsulectomy and maybe a small hole, but by definition it becomes a total capsulectomy. So the en bloc or the total capsulectomy is very good, very safe, very nice, especially the en bloc. If absolutely 100% total capsulectomy. Now what is not acceptable is, and bad and wrong and incomplete and unjustifiable, and in my eyes wrong, is to leave the capsule behind, because that partial capsulectomy means it could be 99%. 1% was that 1%, 5%, 10%, maybe that capsule that was on the rib. That in itself is enough for the body to recognize and impart an immune response and continue to trigger what would be the BI symptoms. Maybe not as severe, but still continue to do so. And that's why it's critical to not do a partial capsulectomy. And that is an incomplete way. And this basically is what I've been saying all along, is not at all the gold standard and not required. And one cannot say, well, I'm going to try to remove the entire capsule, and if I'm not, I'll leave it behind or I'll burn it. No, that is where the partial capsulectomy is. And the capsulotomy, the fourth, and as you'll see on my YouTube, where I'm on the board and kind of describing and drawing the diagram, please go and see it and share it with your friends and colleagues and anyone else on your pages. The capsulotomy is what is the standard of care. If someone goes in with a capsular contracture, the surgeon basically scores or opens up the capsule and now removes the old implant and then essentially replaces it with another, maybe a larger implant, to accommodate what would be an opening up of that scar tissue, which is absolutely not what I would recommend. So hopefully that answers your question. So next, my surgeon told me he'll be able to remove only 95% of the capsule. Now, I will tell you the hardest part of the operation is to remove the implant off of the ribs and also off of the muscle. And then ultimately, sometimes all the capsule may ride all the way up to the clavicle. So that means that making the incision a little bit bigger, you cannot say, I have seen in an operative report, which is wrong. The surgeon said, I removed the capsule as far as my eyes could see. I said, that's, sorry to be using the word BS, but you have to just make the incision 2-3 centimeters bigger, and all of a sudden you'll be able to see everywhere. So don't be fixated on the length of the incision. That's not what is explant surgery. The explant surgery is totally dependent on complete visualization of the chest, very likely below the muscle, and complete removal of the capsule, because that's where the relief lies. Complete 100% removal of the implant and the capsule, because this is where the recovery lies. You have to, and one must, and one has to remove with definitive certainty 100% of the capsule plus the implant as one system, preferably in the end block, or a total capsulectomy with no capsule or inflamed tissue left behind. And as you will see, and I'll mention this again, the next video that I'm going to put forth is that of a patient where it was a saline implant. And remember, it has a nice smooth surface, but that irregularity had formed, and I did it in an end block. And guess what? None of that leaked out, because the commitment was always and should always be to an end block. This is very analogous to someone's going to do a ski jump at the top. And if you're a little bit shaky, if you are not certain of yourself, if you're not confident, if you are not motivated, and you do that ski jump from the top of a slope, you're going to land on the face, which means that you're going to leave the capsule behind. The fixation should be and must be, I'm going to get the whole capsule out, no exceptions, period. Now, I'm going to say this in the world of COVID-19. Look at that small, whatever that amount that's going to be injected into the patients, correct? It's a small volume, or when you get the MMR vaccine, it's a small that's injected into the body, and that small amount is enough of an antigen to mount an immune response. Now just imagine you leave 5% of the capsule behind. And we know with absolute certainty, look at my pathology reports, giant cell reaction, silica, chronic inflammation. If you leave that 5% capsule behind, that in itself, just like that vaccine, just like that will continue to trigger your body into mounting an immune response, and maybe that 5% might continue to burden your body. Now you may have maybe 50% improvement, 30% improvement, 90% improvement, but why not go all the way? The surgeon must commit to 100% removal of the capsule, period. No questions asked, no other commitment. They should not say, well, I'll decide in the OR. Wrong answer. And I say this with all due respect to the patient and all due respect to the surgeon, and this is what I am trying to teach, help, and understand. And I say this again, the bounce back, the recovery, the good health, the nice state of health after an explant is totally dependent on the entirety of the implant and the capsule being removed as one system, preferably an end block, or 100% total capsulectomy with 0% of the capsule or the inflamed burden remaining behind, such that the patient gets a chance to bounce back and the patient has no trigger within the chest that will cause. Now, this one patient that has 40-year-old set of implants, or the patient that I'm going to do tomorrow, my third patient, she had a ruptured implant on the left side from 2018, residual capsules. She had set of implants from a long time ago, approximately 30 years ago. In 2018, she had the ruptured implant on the left removed, free-floating silicone on the left side. On the right side, she had a leak, contained focal leak, drains for 2 weeks. She now comes in with signs, symptoms of BII, replete except for one. Tomorrow, I'm going to go ahead and remove the residual capsule, any potential silica that might be behind, and any inflamed fatty tissue, bad tissue, whatever it may be, such that she gets a fair chance to bounce back. Now, the one thing that I'm not going to focus on are the lymph nodes. I'm not going to remove the lymph nodes in the axilla. Number one, that's not the commitment I have. What if I remove and the next thing you know, she has lymphedema? That's another set of problems. I don't want to. My job is to remove the entirety of the capsules plus the inflamed, necrotic, whatever fatty tissue, reactive tissue that might be there. And I know she's my third case for the day, and I might take 4, 5, 6 hours. The last one I did, the lady from Texas, I spent 6 hours just to removing the capsules, where the surgeon had attempted to remove on the right, and there were pieces of capsules that he had removed, leaving 70-80%. And on the left side, essentially the gist, he didn't even bother to remove the capsule on the left side. And I sent those capsules off to pathology, and you'll see in my private breast implant illness Facebook support group page, those capsules came back as foreign body reaction, silica, and again, all what is consistent. And lo and behold, the patient just a couple of weeks posted how her face has changed for the better, her resolution of sign symptoms of what was residual removal of the capsule, and hence her bounce back. So hopefully that answers the question. Now what I want to go ahead and do is, hopefully you found this informative. I will go ahead and do one more Facebook Live before the end of the year. I'll try to go ahead and do a Facebook Live from the OR in the next couple of weeks. Hopefully I find an interesting case. I want you to please go ahead and ask questions. Write the questions down. Whenever you go see your plastic surgeon, you should have question 1, 2, 3, 4, 5. If you can go to the breast implant illness support group by Nicole, good friend of mine, she has in it a direction as to what and how you should ask those questions. What I want you to very assertively ask your plastic surgeon. Don't be, I don't want to use the word submissive, but don't be naive. Be well-read. Be very nice, assertive, respectful of the plastic surgeon. He or she is entitled to their opinion on a topic that's not well understood and not well accepted. I say this, whatever I mentioned today, and from my experience, from my heart, from my mind, from what I know, 10 years from now, I strongly believe what I just mentioned today would still hold true, and hopefully it will withstand the test of time. I say this to you, do your homework, talk to the other patients. That's your best bet. That's your best resource. The other patients, what they have gone through, what their experience was like, what their experience was like with the surgeon, so that you get the care that you very much well need and deserve. Now, having said this, I just want to wish everyone happy holidays. Wash your hands, wear the mask, contain yourself, limit your activity outside. As you can see, COVID is coming back with a vengeance, even higher and more angry than before. I will the validity of the vaccine in itself is a topic in itself, and I won't go there. But I wish everyone the very best. Stay safe, keep smiling, do your homework, do your research. God bless everyone. Take care and all the very best. Till next time. Thank you very much.